Good morning, everybody. Thanks for the intro, and it's really great to be here. I'm Ben Smith, a clinical specialist. I'm based in California, and I come to Florida quite often. There's a robust team of clinically minded sales reps that get me here as much as humanly possible, and I'm looking at one right now. And I enjoy working with the team. I really like this community of perfusionists. You all are a very smart, clinically minded bunch. I go everywhere in the US, and that mindset, unfortunately, can be rather regional. So I love coming here. July is tough for me. I'm not gonna lie. It's tough to come to Florida in July, but I do. So thanks for having me. The Medtronic, we're gonna be talking about the HMS Plus. And how many here use an HMS device in their hospitals now? It's a lot. It's almost probably 80% of the room. Medtronic worldwide has close to 60% market share, and that's true for the US as well. The coasts, East Coast, West Coast, are more like 75%. And I think that really bodes to the level of clinical awareness and clinical mindfulness that your community and your perfusion department share. So this is going to be more of a review rather than an introduction, because comically, this is not a new device. This is a staple of cardiac surgery. But it's not this new, we're not Apple where you're gonna get a new gen of software and updates every 2 years. This is been in the market for a while. So I treat this as a, you know, let me see if I could just. I treat this as more of a clinical review of a device that's currently used. I find that people have different protocols. They have different parts and pieces of the device that they use. Some are left off, some are included, but I think the most successful programs that get the most clinical benefit from the instrument are the ones that do the protocol start to finish. They handle the heparin at the start, they treat off a heparin level during the case, and they follow the recommended, usually lower protamine dose that they would have tested for empirically. I'm going to try to get all this. I'm going to try to clean this. It's up a little. Great. Well, looks great on my screen. There we go. Okay. So there are 3 families of tests for the HMS. The heparin dose response used at the beginning, the ACT, and then obviously the HPT, heparin level, used during the surgery that is folded in with the activated clotting time. But to kind of step back, and I'm not going to go through the coag cascade. I don't want you to storm the stage and murder me at 9 o'clock in the morning. So this is as elaborate of a coag cascade review as I was going to get. But this is what you're dealing with in terms of anticoagulation management as perfusionists. Your thrombin is getting assaulted from 2 main areas: a hemostatic or a contact activation, which is your tubing, your assault, what you're harvesting, that type of thing. The other is the tissue damage, and that's especially the harvesting. So on a case where they have to get the saphenous, where they're doing the IMAs, that is going to flood the system with thrombotic activators and really ignite thrombin. And our goal is to keep thrombin subdued. We don't want to destroy thrombin. It's a fine line of keeping it intact, but keeping it workable because we need it at the end so we don't bleed so much and have to give all sorts of blood products. So that's the goal. Let's suppress thrombin, but not destroy it. And the way we do that is with unfractionated heparin. Heparin is a very tricky beast, and it got trickier a few years ago when the source changed. I see, it was rough. It was rough for you guys, and it was rough for the cath lab. It was rough for interventional radiology. because heparin itself is variable, but then we went to the WHO's formula of strength. So all of a sudden you grab 10,000 units of heparin and you think, you know, I kind of know the range of clotting time I'm gonna get. And it was 25 to 30% less than your target. And it was a real education era for us to make sure that the pharmacy was telling you that this old heparin is now not stocked. This new Chinese-based WHO formula of strength heparin is now on your shelf, and expect some efficacy differences. That was tough. That was 2011, and it really kicked in 2012. But heparin is our quickest and most cost-effective way of suppressing thrombin. And it has a lot of variability on how it's going to affect each patient. The heparin itself will vary quite a bit. It's a heterogeneous substance. The molecular weight changes, the Daltons change, the saccharide chain length change. All of this makes heparin inertly rather variable in and of itself. But it does work to inhibit the thrombin and to anticoagulate the patient. And the mechanism is rather straightforward. It goes to work with AT3. So if you don't have enough AT3 in your system, despite a lot of heparin, you're not going to get that bump that you would expect and you hope for to be safely on the bypass pump. Heparin itself is very biphasic in its metabolism rate. The typical, this little in-house study was done at Medtronic, and they took a variety of patients and it was an in vitro study rather than an in vivo study. And they took the clotting time after giving about 300 U per kg of heparin, and they looked at the metabolism rate of their ACTs at different points of time. And they found that their ACTs went a little bit above 400, which a lot of you may go on pump at 400 if you're giving 10 in the pump. Kind of depends on how literal you follow the ACT and your clinical benchmarkers to proceed. But what we found is the amount of metabolism was remarkable in the first 10 minutes. That was the biggest drop of ACT, and then it sort of levels off in a more linear fashion. So I guess my point is, for those of you doing the HMS and getting your heparin dose at the beginning of the case, you might get a heparin dose at 7:45 a.m. and not go on pump until 8:45 a.m., especially on a cabbage where you've got to do a lot of that harvesting. Just be aware and be cognizant that dose that you got at 7:45, you may be a little short at 8:45 when you bolus, because you've really assaulted the hemodynamic nature. You flooded the body with thrombin. The surgeon has. You all haven't yet. The surgeon has from all their harvesting and getting the saphenous vein and doing the IMA. So again, thinking that heparin is biphasic in its metabolism rate, just know that it can be rather fast and furious in the first part after you bolus the heparin. So let's talk a little bit about heparin itself. It does have a wide variety of efficacy. It's very patient dependent, and it's very dependent on the antithrombic or the AT3 level per patient. We talked a little bit about how the molecule itself can vary. It can vary brand to brand, lot to lot, by the way. We've got a really great set of studies at our booth that shows how heparin's strength and efficacy can vary even with, and any brand of heparin, you name it, with different lots over different amounts of time. And that's unfortunately truer today than it was prior to 2011 when we acquired this new, less efficacious heparin. But the half-life is less now, and I find that when I go into surgery and I'm doing in-servicing or education on the HMS or a trial, the consumption rate and the drop of the heparin assay in relationship to the metabolical rate, the metabolism, is faster now than before. Usually you could say, yeah, no, I'm not going to give, probably don't need to give heparin all the time, every half an hour, every 45 minutes. I see a lot where you do. And it's not a function of, oh, that darn machine always wants heparin. It's picking up you need heparin, but it's a big, big function of the lack of efficacy of this newer heparin that kicked in 2012. This is kind of a summary. The good old day, who here remembers using beef lung heparin? I mean, wasn't that a good day? Because it was more reproducible, you had a better feel on how it would react. The half-life was longer, then mad cow kicked in, and we went to the porcine mucosal, and then obviously in 2011, 2012, we changed that to this new strength formula that's less than what it was. So heparin has changed, and unfortunately I find that the pharmacy, when they change, always doesn't tell you we've got a new brand of heparin. Sometimes, unfortunately, Perfusion, and we help you, have to dig for that answer and dig for that understanding that, oh, we changed from brand A to brand B, and now my response curve is different than what I had with the previous lot. The cath lab finds that a lot. They don't use typically a dosing tool. They're starting to more and more, but they typically weight-based dose their heparin, get to a 250 or 300 ACT, and so often they're coming up short. So if you're going through and you've been through that whole dynamic frustration, unfortunately you are not alone, and it is not singular to you all. So the point is that good heparin management is more important today than ever. Your patients are receiving antithrombolytics, Plavix. They're receiving a whole host of things by the time they land in your OR suite. The good old days is, you came straight to open heart surgery. You didn't need all those interventional exposures to heparin and antithrombolytics and all the other things that really make this, this day for you more challenging than ever. We're seeing more and more heparin-resistant patients. Here's a show of hands. Are you all typically seeing more heparin resistance? You are? It kind of varies. I see about half and half saying, yeah, we're seeing more and more. It's not dramatic. Every now and then it could be. Repeat the HDR if it is. But I find that probably half of who I poll say, we are seeing a more resistance. And other times you get the ones that are not, and those are the cases you love. So this is a challenge, and for the non-HMS users who aren't as familiar with it and more still ACT based, and even for current ones, sometimes there's this question of why is this darn thing asking for more heparin, and I have a 600-second ACT? It can feel counterintuitive to give a little bump of heparin when you've got a nice high ACT. It just feels strange. Well, there's some clinical reasons why that extra bit of heparin helps preserve the clotting factors of the patient. And these are the three categories of what can happen if you've got a higher ACT level, but you're actually running at a low heparin level, and you're subtherapeutic. And if you're subtherapeutic, it doesn't necessarily mean you're going to get this giant clot in your pump. You're not, you're not in a crash situation. It means, though, that hemodynamically, the patient is in a consumptive state. That thrombin is still active and getting consumed. So after surgery, not so much during surgery where you're, flying the ship, but after surgery, those patients tend to be wet. Those are the ones that tend to need blood products to get them back to a normal stasis level. So the ACT, I think of a very simplified bifurcation of how ACT and heparin level coexist. I think of ACT as protecting your circuit. We don't want clots in the circuit, of course. But I think of the heparin assay and monitoring that with the ACT as helping preserve the clotting factors and clotting ability of the patient. So what I like about this community is that there is a very prevalent mindset of understanding that an ACT alone, although it's the standard of care, it doesn't do everything to preserve the clotting ability of the patient that they need so desperately after the case. It's going to protect your pump, very important, hands down. But let's also fold in another assay that's going to detect a drop in heparin, and that's going to keep that patient out of a thrombolytic state. And if your patient's getting to a subclinical level where they're in a thrombolytic state, you don't see that on pump. That doesn't, you don't have a measure for that. Well, we do. It's the heparin assay that most of you are using. But some of you all, it's easy to not think of it like that, but I think of things in a more basic term, ACT for the pump and heparin level for the patient, and the combo of those two is very powerful. All of you have blood utilization committees and may sit on them. This is a common slide that I send to blood product committees to help them understand. I send these to point of care a lot too, because they really don't understand why you may want to get another assay in, monitoring it with an ACT. I send this a lot, and it helps them understand how a heparin level complements the ACT. And the big one is the middle, the depletion of clotting factors and AT3 and the functional platelets, all those things that you need after surgery. So this is the benefit of doing the heparin level. This isn't so much a dosing benefit as it is a benefit during the case when you're running your ACT's high, but that blue or tan cartridge is calling for a little bit more heparin. You're like, wow, 625 ACT, should I? Well, this is what, by giving that small increment of heparin, this is what you're handling. This is what you're handling behind the scenes. So to now go back to sort of a review of those three families of tests, the HDR, this is your first baseline ACT. When I travel around the US, I also find that the understanding of the info that this provides can vary a lot. Some hospitals are just like, tell me the dose. Just tell me the dose of heparin so I can do it, and I'm rocking and rolling, and I'm kind of in my brain going to compare it to what I empirically might have given at 300 or 400 U per kg. But I just want to remind you of the four important pieces of data that this gives you. Number one, and by the way, you know, this is a bull curve. We're doing a 6-point bull curve here. We've got 3 levels of heparin preloaded into the cartridge, and we're going to discover the ACT growth with known amounts of heparin, a bull curve. And when this is done and clotted, you'll get on the strip a slope value. I'm always surprised how many places don't really look at the slope, but that really determines everything for you. And I also talk about the slope too because it's something that your point of care folks should monitor on a yearly basis. And that avoids you having to do QC on this cartridge. So the slope is important, number one, clinically to know and understand, but also from a regulatory standpoint, they're going to ask you to collect probably 30 to 50 slopes every year and just give you a slope value and make sure it doesn't deviate dramatically calendar year to calendar year. But the slope itself, that's just the bump in ACT that patient gets with every U per ml of heparin. And an average slope used to be 100. Those were the good old days. Those were the, the pre 2011 heparin. I just did a slope study this year in Tampa, or this week in Tampa, and we were getting about a 90-second slope. So it's gone down, and what that means is for that typical patient, for that particular patient, the average patient, they get a 90-second bump in ACT with every U per ml of heparin. Here's what's nice about knowing that. First of all, that's going to help determine if you want to get out to 480 or 400 if you're running a lower protocol. It's going to mathematically be the calculation of what to give. But the lower the slope your patient has, as a rule, they tend to chew it up faster during the pump. The resistant patients tend to metabolize faster than your normal patient. So I love knowing the slope because it gives you a snapshot of what you could be in for once you're on pump. Those patients with the lower slope, I don't mean like, 40, because that's insanely low, but something usually in the 70s or 60s, they tend to chew it up faster. And when you discover the slope value, then it's using, of course, your baseline ACT, and you're getting your heparin bolus, and it's also assigning the heparin level to maintain that equates to your ACT target. And we're all different. We all want a 480 ACT, but I'm unhealthy, my BMI's high, I've been to the cath lab, I've been on Plavix. The amount of heparin it's going to take me to get to 480 is going to be different for somebody like you whose normal BMI, healthy parameters, doesn't have all those comorbidities. We're still going to 480. Everyone's getting to 480. How much will it take is going to be determined by this particular test. And then the device is going to look to maintain that number as well as the ACT. And just kind of back up on this slope, so the part of the protocols that your point of care folks may ask you to do is to give them, some do 20, some do 50, slope values at the beginning of every calendar year. And what they do, they discover what your year, of those 20 or 50 patients, whatever N they decide, it's your mean slope value and range for that calendar year. And it's not built into the instrument. It's not like it's critical values that are set in the instrument, but they want to put in their policy, hey, at Tampa General or JFK Med Center, the normal slope is like 85 seconds, and here's the range for that. They want to make sure that that range doesn't deviate by 12% the following calendar year. And by them doing that, that alleviates the need for doing any quality control on that particular assay. So the reason why I say this is there are point of care institutions that will pressure you to give up the HMS in its entirety, or at least this particular test, because their claim is there's no QC for it. Well, I'm happy to handle those people, because for them, we've got a set policy of handling that particular requirement. They just may not know about it. It may not be in their SOPs of regulating this instrument because they could be old. I've got cards. I'll handle them just fine for you. I handle the lab. It can be an art, and they're very regulated, but I understand that very thoroughly and can help them. So if there's ever pressure to say, stop using this cartridge, there's no external plasma QC for it. There's not. We're not making it. It's not required, but we have a way for you to comply, and I'm happy to send them all the data they need for that. Oh, sorry, one more key component, the most important. An ID, if you all identify a very resistant, heparin-resistant patients, how many of you give thrombate or AT3? Excellent. I sound like Monty Burns. Excellent. How many of you give FFP? Okay, a little less. And how many of you just don't do any and then you just go with the big heparin bolus? Okay, good, because those are the three decision trees. Typically give an AT3, give FFP, or just go with the bolus because we understand that AT3 is expensive, or you understand that FFP isn't ideal, so we'll just go with the giant bolus. Those are really your three decision trees to use. But what's great is this will tell you. And typically I get asked, well, what's the trigger to treat on using this test? What's kind of the trigger that I might need AT3? That really depends on you all. A common number that I see is a slope below 60. Again, up to you all to establish and decide, but when my travels, that's a common question that I get is, what number do you recommend? We don't recommend it, we just give you the tool to understand, but usually I see a slope below 60, they're now thinking of thrombate or AT3. And then you would want to give that and retest your HDR, and then you'll get a much normal, typical bolus of heparin. I'm seeing more and more of the AT3 route than FFP. And especially, I mean, I'm not a paid AT3 person, so it's just in my experience, if your goal is to give AT3 as a correction, there's not a ton of AT3 in 2 units of FFP versus a vial of AT3. So if that's your course of treatment, I see places that just bypass the FFP route and they go straight to the AT3, and it's a much more concentrated amount of it. And that's again, I don't rep it, I just understand it, and I see it used more and more all over the US, and that's a typical protocol. So they would correct that odd low slope with something like that, and then retest your HDR, and then get a much more normal heparin dose. I'm not going to go too much. This is just the functionality of how the HDR works. With known amounts of heparin, the increase of clotting time will determine your heparin bolus. So this is a normal versus resistant. This is actual patient. These were two people at Medtronic they both had the exact same baseline ACT. And the goal was to get them to 480. But patient number 1 required about 3.8 U per ml of heparin to get to 480. The lower patient, or the more resistant patient with the lower slope, required about 5.2. Same baseline ACT, but boy did they respond differently to heparin. So let's just talk a little bit about our ACT itself briefly. It's an important test. It's a very global test of coagulation management. It's more of the effect of heparin and how it's doing, but it's not specific to heparin. So when you're on pump, and especially if you dilute, a small amount of dilution will elongate and give you a false positive ACT. When I do if you ever get a new device, we can help guide the lab on the validation procedure, and one of the tests that we help them with is a linearity study that looks at the relationship in the growth of ACT to known amounts of heparin in vitro from a donor with spiked heparin in a tube. That has a very high correlation of heparin level to ACT. When it's your world and you're on pump, and again, you've assaulted the thrombotic system with all that is just what happens in surgery, the correlation of heparin level to ACT nosedives. So if you want to be at 480 to be safely anticoagulated, but you're on pump, your 480 may not be a 480. It could be less. Maybe it's more, but the correlation really reduces. So it's also a poor indicator of heparin reversal. I was in an account, not on this coast, and they basically said, wow, my final ACT was, I've been on pump for 2 hours, my final ACT was like 750, so we'll just go ahead and give 500 milligrams of protamine, based on the final ACT after a 2-hour pump run. when the patient was 30 degrees. So it's, of course, we ran ours behind the scene just as a comparative, and they needed about 190 milligrams, not 500. So it's a poor indicator as a final measure of the amount of heparin that you need. So let's talk about what I call the kind of the engine of the device, and this is what's used. This family, this heparin assay, is used during the case and as well at the end to determine, reversal of your heparin. This particular family of tests is not an ACT. Even though it'll tell you that it took 60 seconds to clot, it's not an ACT time. This is our heparin protamine titration. Does anybody know what's in here? It's a thromboplastin base with added and varying amounts of protamine sulfate. So that's how it determines the amount of efficacious heparin in your body, is that amount of heparin in the sample that gets reversed with a known amount of protamine. It's a titration. And your point of care folks will also want to drive you batty when they say, oh, you're doing a heparin level? Well, let's go ahead and do a correlation to an anti-10A assay, because that's the gold standard of heparin level. That's a tough correlation to do. That's more for newer users that point of care and pathology may want to have you do. I'm happy to get involved with that. It's a tough correlation to do because a 10A is run on serum. We're thromboplastin and protamine sulfate. So if you ever get hit with, well, why don't you're kind of doing a 10A, right? You're not doing a 10A. You're doing a heparin protamine titration, and you're using it as a guide to heparin level. You're using it as a guide. And that helps kind of calm them down that we're not replacing a 10A. We're doing something similar, but yours is in a much more general mindset of monitoring that patient on bypass than their finite slicing and dicing a 10A assay. I deal with that a lot. It also gives you your protamine dose. Show of hands, how many places get their protamine dose, but anesthesia does what they want? I know. Yeah, it's a good 25. And sorry, not to single you out. I wish I had a light I could like shine on you. But how much do they typically give empirically if they're not following this one? Then it says, okay. I know, I hear that a lot too. I know, exactly. Do you keep your heparin and protamine ratio 1-to-1? 1-to-1, just knowing that they're going to give. Well, this is a crafty move too. If you lower your ratio and they're extra, you'll probably land at 1-to-1. I had an account on the West Coast do that. They lowered theirs to 0.8-to-1, knowing that anesthesia was just going to give they're going to give another 100. That's just what they do, and it's just how it is. So that was sort of a workaround with that. I don't recommend that, but I think perfusionists can be a smart, crafty bunch when needed, and that's how they did it. This also reports, as you know, in 250, 300, groups of 50 U per kg, and a common question I get is, oh, my target is 310 U per kg, and I'm using a cartridge and I get 300, and it's always asking me for a sliver more of heparin. That drives me crazy. It's just, if your target is 310 U per kg and you're getting 300 U per kg, you're at target. But mathematically, the instrument is looking at that 10 U per kg and saying, ooh, you're at 300, give a little tiny bit more. I would ignore that. So that's a common scenario when I'm getting new people up online is if you're near target, you're at target. So if you're monitoring a 360, if your instrument wants to monitor a 360 and you're at a 350, I wouldn't keep giving that. That's just me personally. Don't want to tell you how to do it, but I wouldn't keep giving that incremental amount because you're a target. Oh, and one more thing about this is there's sort of, I get hit with a lot comically, like, well, it always says 0. It always comes back 0. When does it not come back 0? When does the protamine dose not come back 0? Well, if it kept coming, registering, you need more, I'd be a little worried about the efficacy of our protamine dose, but I understand what you mean. The time that I see the reversal cartridge registering heparin is 20 to 30 minutes afterwards on higher BMI patients. That's when I see the red cartridge registering a need for additional heparin. And it's a function of heparin rebound from the higher BMI patients. Not every time, but when I see this register, the need for more, that's usually the scenario. Not right away, not 5 minutes post-protamine, but more like 20 to 30 if the surgeon sees that the chest is getting wet. A lot of times they'll just run this. They might not even run an ACT. It may not be enough heparin to really bump an ACT clinically. There's such a large range. But I've run this 30 minutes post-protamine, and my ACT came back exactly the same before, but this had registered that you are in need of about 30 milligrams more of protamine. It wasn't enough to really move the ACT. So that's where I think this is a huge clinical benefit to help your surgeons understand that if you're wet, just throwing extra protamine isn't the greatest, because protamine is an anticoagulant. Another case I was in where 500 milligrams was a standard protocol for everybody, and that's just what they're used to. And that was a function because this practice was having to give so much more heparin because they couldn't get to target due to the less efficacious heparin that's today. So their fix, rather than being specific, was just, we'll just give more heparin and we'll just give more protamine, and that'll cure it all. Well, it made for a host of new problems that they're dealing with now, and we're helping them get through it and get to a more specific mindset. So they gave 500 milligrams of protamine, and we had suggested about 210 or 220. I knew that red cartridge would come back 0. Of course, there's no more heparin on board, but the time it took for that cartridge to finally register was about 150 seconds. Now, when you guys do that red cartridge, you know it takes probably about sometimes 40 seconds. It's usually within a minute for the red cartridge to finally register a clot and say 0. The longer it takes for it to result, that's a sign that you have a level of anticoagulation happening, but it's not from heparin. It was from the excess protamine. That's all we could deduct, was that excess, that extreme overage of protamine. Of course, it handled all the heparin, but all that extra had an anticoagulation effect in the patient. And what did the surgeon see? Saw a wet patient. What did he decide to do? Give more. Give 100 more. So, again, it's the back and forth that you're avoiding by honing in a more specific approach. But protamine on its own is rough. So I think just that extra 50, that I know it probably makes you crazy that they're giving more. I see it a lot worse where they say, oh, give another 200 or give another 100, because they kind of empirically like that number. So we've got also a library of studies that shows how protamine acts as an anticoagulant and how it's tough on the inflammatory system and the platelets. So if you need some clinical guns to get them thinking about a more specific approach, we can help you. And the bottom line impact is, again, when you start at the beginning with tightening your heparin and being specific, on pump, monitoring the ACT, of course, but also treating off the heparin level and then customizing your protamine dose based on a titration, which, by the way, the STS guidelines has made that even a more important category of regulation, the protamine side. Not base it on last ACT, but basing it on a heparin titration. This is an old study, but this is what the collective benefit is. Drier patients, less blood products. That's the collective benefit. And I always ask, who's hearing the rumbling of a blood conservation committee? Everybody is. Everybody is. And even though your blood product usage may be relatively low, they always love seeing an improvement. They always love seeing an improvement. And I really like the perfusionists who have that mindset and bring that sort of approach to the OR. I think it adds value to the perfusion community, to the cardiac surgery room, when you say, we want to do some things that are going to reduce blood product and improve your outcomes, doctor. I mean, that's pretty powerful. This is a great study. Again, a little older, but it shows how roping in that heparin assay with your ACT calms that hemostatic system, and the end use of that is a reduction of blood products and reduction of blood products in drier patients. This is DESPOTUS. And here are a few more that deal with the cost of things. I've got a question. How many of you charge for the heparin, the HMS tests? Do you guys do any individually charging, or is it all rolled in? All rolled in? No, you charge for this? That's great. We have CPT codes for all our tests. There's a CPT code for your HDR at the beginning. There's a CPT code for your heparin assays, and then of course your ACTs. And I'm always surprised at how many places don't capture that revenue source, because you have to do QC. There's a cost to managing that benefit to the patient, and a lot of times it's rolled into the DRG. It's just rolled into the total cost. But I'm seeing more and more break it out and bill for it. So if any of you need CPT codes for that, I've got them. It's a quick email, and I can get those for you. But that also helps pay for new devices. That's an equation that helps pay for using it from the start, let alone all the blood product savings, because that's a very concrete analysis. When we do a blood savings analysis, you look like a rock star. You do. And the CFO, they may get in a little, sometimes they don't like, quantifying bring back time or OR time. That's a softer cost to them. But we have a really good matrix of helping quantify the hard cost benefit of using an individualized dosing system versus just an empirical shotgun approach. And this is also, we're also huge in pediatrics. Huge in pediatrics. How many of you all do any pediatrics with HMS? Do you? Okay. Do you do the HDR at the beginning? You do. Perfect. And then how often are you testing your ACT? Perfect. Do you do a heparin level with the ACT? Okay, great. And is your target 480? Okay. For all those out on the web, that was yes. So, thank you. Yeah, we're doing more and more with peds. They can be challenging, and with pediatrics especially, because your volume ratio is so big that it really wrecks your ACT. When I go in these pediatric cases, once they go on pump, I got a 999 ACT the whole darn time. So they really depend on that heparin level. So that's kind of it for my slides. I hope this was a review. Any questions about lab or the use of this or QC things? I'm open and I'm here all day.